Okay, good morning. Thanks very much for inviting me. It's quite a privileged position going third because I can listen to all the difficult questions the others have answered and tailor my presentation. So hopefully there won't be any difficult questions at all when I come to the end. Whoops. Okay, so I'm going to talk a little bit about the national picture, but not very much because you've heard some of it already. I'll talk at more length about our vision and approach in South London, and then just to illustrate it, I'll talk about one of our clinical themes, just to talk about how we're going to go about it, then a bit about our governance, and then some next steps, and then answer some difficult questions. This slide comes from the national presentation that Richard Gleave and Ian Carruthers produced. I don't think the detail's enormously important, but as we all know, this came out of the Innovation, Health and Wealth that was launched in December last year by David Cameron, alongside, and I think it's important that it's alongside the life science strategy. I think there's a philosophical view at government level that the health service kind of takes from the public purse and doesn't give anything, that all the kind of talent and ideas that we have sit there soaking up money and don't make any. So I think there's a real appetite for changing that. And I've heard some of the discussion earlier about structures and process, and actually I don't think that's the important bit. I think it's cultural. I think we need to change the way we behave, not the way we set ourselves up. And actually I think there's a real opportunity at the beginning of the AHSNs, before we have a lot of resource and a lot of bureaucracy, to be nimble and actually really to be innovative. I think once we're a couple of years into our 5-year licence, we'll develop more and more infrastructure and superstructure, and we'll become more like the old NHS, and then we'll reinvent the past, and that'll be really sad. So I think now is the time that we should be getting on with things and really embracing some difference and actually taking some risks, and that's one of the things where working without the NHS is helpful, because we're not great at taking risks. It's no good being a cardiac surgeon if you're a risk taker, really. That gets you into rightly gets you into trouble. And as a lapsed renal physician, I was terribly risk averse. Maybe why I've moved out of renal medicine is because I secretly quite like it. So what Ian Carruthers said to the managing directors of the 15 AHSNs a couple of months ago was that the AHSNs have just got to do two things, and I like Ian. I think he's very clear thinking, and what he said is they've got to improve outcomes for patients and they've got to create wealth for UK PLC. So that's it. So he said when you write your application, if the vehicle that you describe is fit for that purpose, you'll get through and you'll get your licence, and if you don't, you won't. So I think that clarity is really helpful. And again, a kind of personal bias from me. What I think, and I've heard people talking about it this morning already, is actually we're not short of good ideas, but what we're pretty hopeless at in the NHS, and where I think we've got a huge amount to learn, is how we roll those out. And I think we get that wrong in two big and important ways. The first is we have some really good schemes which improve the lot of patients, which improve outcomes, but they get circumscribed by geography. So if you happen to live near the institution where the local clinical leadership is good and they develop a really good scheme, then you get looked after well. If you don't, you get looked after terribly. In London, Tower Hamlets has got a really good scheme for diabetes, and outcomes are good, and they can measure those and prove they're good. The same's true in the London Borough of Bexley. However, none of the kind of methodology that used is particularly sophisticated or particularly clever, although in both cases it's got a lot of patient and third sector involvement in design, but none of it's particularly sophisticated or clever. But if you live in an adjoining borough, if you live in Newham, or if you live in Bromley, or if you live in Merton, you don't get those benefits, and actually that's pretty disgraceful, and we need to do something about that. And the purpose of the networks is to cover the whole country, and so you don't get this kind of lottery as if you live near an inspirational clinical leader or generally live near a teaching hospital, you get a better deal. So that's the first bit where we don't do well with innovation. I think the second bit is more subtle, which is where we've developed methodology which improves the lot of patients, but that methodology is highly generic, but we have this mad idea that it's specific, and so we don't roll it out to other areas. And again, in Chandy's specialty, after Bristol, when there was the scandal of the heart surgery in Bristol, the simple measure introduced by Bruce Keogh and others of publishing results in cardiac surgery and the mobilisation of peer group pressure has halved the mortality in all cardiac surgery, adult and childhood, since Bristol, and saved hundreds and hundreds and hundreds of lives. It's not very clever. Interestingly, the rank order is the same, but everyone's twice as safe as they were before, and probably a few people who weren't doing enough operations have been eliminated, and that's been a good thing. But that's great, and that's a good thing. But what's sad about that is we haven't rolled that out to other areas. There are very, very few examples of us doing that in other areas. And that's why I was really pleased to see the EQ stuff, which I've seen before from Kent, Surrey and Sussex, where they are trying to mobilise that. And I'd have been looking at that carefully, and I got my glasses on today, and I'd have been thinking, you know, why is it that at Chichester and Worthing, 90% of people are getting the correct intraoperative fluid management, and in some of the other organisations, we won't name them, it's less than 10%. It's not good enough, is it? So what we need to do is roll out generic methodology that works well to whole populations, and that's what the AHSN needs to do. But I'll go back to my point. I think we need to do it early on in our lifespan, not develop big bureaucracies and big infrastructures, and actually do some stuff. And hopefully that's one of the things we'll do in South London. So when we wrote our bid, we were told we had to do 6 things. We had to increase research translation and increase research participation. I'll talk about research participation a bit. We had to drive service improvement, which I'll leave till later. We have to use information more wisely. We have to create wealth, and we have to work together on education and training. Richard Gleave and Ian both talk about this 3-legged stool of academia, of industry and the NHS. That's the ABC that David put up at the beginning. And one of the things that I hear when I talk to people in industry, both in terms of the wealth creation end and in terms of the research participation end, is how unbelievably difficult it is to get into the NHS. If you want to run a clinical trial across the whole of South London, you've got to go through an approval process in over a dozen different organisations. If you've got an innovative idea, exactly where you come to in the NHS to get that rolled out is perilously difficult. And we need to use the AHSNs early in their lifetime to make the portal of entry into the NHS, the gateway that David talked about, much more straightforward. And if we don't do that, we'll fail, and pharma and other industries will take their innovations to Scandinavia and elsewhere, and that'll be the opposite of wealth creation. The other bit about wealth creation is I think about it in 3 ways really, and I think the third way is the most exciting. The first bit is it is appalling, the variation in the quality and the way we deliver healthcare, and the way we don't deliver the best evidenced healthcare everywhere, and that costs money. Giving people MRSA, allowing people to have venous thromboembolism costs money. Keeping people in hospital longer than they need to because we're not using the best fluid management technology costs money. So there's the simple bit about ironing out variation and taking costs out. That's kind of simple. There's the old-fashioned bit where we think about people like you as a bank, so we can do the things that we want to do anyway, and that's really the kind of the model about trials with pharma and introducing technology. But then there's what I think we really need to make this about, which is really working together, where we've got stuff that adds value and you have stuff that add value. And I'll use an example of something that we're hoping to do in South London to illustrate that. So we've been working with a small firm who I won't name, who've got some technology which has been developed in elite athletes to do physiological measurements on people and match that up to a diary card exercise. It's quite simple technology, but it's got some evidence base of being effective, and has worked with elite athletes in another European country. They've managed to sell this technique to some elite sports teams in this country, and it looks good. However, there's a real opportunity to use that technology in chronic disease to improve the health of the people with chronic disease who are a huge burden on the health service, and the people who will bankrupt the NHS if we don't look after them better. They've got entrepreneurial spirit, and they've got a really good idea. What we've got in the NHS is academic rigour about evaluation, and we've got access to a population. And if we use this single portal more wisely, and we use our evaluative expertise, we can work in a genuine partnership with these people with a gain share, and then roll it out to other jurisdictions. And we're talking about doing this in our diabetic population, which is one of our priorities, but potentially in our NHS staff. And we're hoping we can reduce some sickness absence, but also improve their ambassadorial role outside the NHS. So I think that's something, it's a small example and actually relatively frivolous, but it is an example of doing something rather differently from the traditional model of just cost saving or using people without the NHS as a bank. The kind of other point I make on this slide is about participation in research. I think we need to win an argument about participation in research. We need to win the argument, which is, the evidence for which is there, which is when you're a patient, you need to be demanding of the doctor or nurse or therapist that looks after you that you do participate in clinical research. Because people who participate in clinical research, whether it's about drugs or devices or techniques, get better outcomes. The evidence for that is absolutely overwhelming. But if you look at research participation, if you look in South London, the patch that I'm responsible for, we're actually the second best of the networks, the comprehensive research networks in the country for research participation. But nearly all the research participation takes place in King's Health Partners, the Institute of Psychiatry in St George's. And so that covers, I don't know, maybe 800,000 of our 3.4 million population. So, 2.4 million people, 2.6 million people, 2.6 million people are not getting access to the best care. And it works for patients. If you look at childhood leukemia, where the mortality survival ratio has reversed over the last 20 years, that's because of extremely high rates of participation in clinical research. If you look at the strides we've made in HIV care over the last 20 years, part of that is about very high levels of participation in clinical trials by a patient group who demand to be involved in clinical trials. So we need to change, and again, this is a cultural change, not a structural change. I'll have a second final point on this slide, which is the relationship with the academic health science centres. I think the academic health science centres, and there are 3 of those in London, are an important resource to the network. But in some ways, they're there to generate some of this innovation and some of these ideas. What the AHSNs have got to be is much more practical. It's about rolling out that innovation to larger populations. So I think it's very easy to go back, to what's very sexy, which is having a whole bunch of new ideas. But actually what we need to do is go back to what's more pragmatic, which is delivering them. Okay, so there are 15 of these in the country, you don't need to know that. I'll just talk a little bit about our footprint in South London. And there's a kind of relatively important bit on the slide, which is we've put, trying to get a pointer to it, but anyway, you can see it in very small right in the top. We put public health and social care at the top, and we've put other stakeholders, so patients, third sector providers and community providers at the top of the list. It's only a small point, but it's not an accident. So if we don't get the whole partnership involved in this, it will look like something that is centred around the academic health science centres and will reinvent the mistakes mistakes of the past. Okay, these again is a list from the kind of national set of priorities. They're pretty obvious, but these are written by Ian Carruthers and Richard Gleave, and leadership, which I think is the bit about culture, and partnership with industry, and the focus on innovation, health and wealth are at the top, and they mean that. Our applications won't go through the next stage if we just play lip service to this bit. I didn't write this list in this order. It's part of the national programme. I'm not sure that I like the patient-centred benefits being at the bottom, but never mind. Okay. So what are we going to do in South London? We would like this to be more ambitious, but I think more practical than any previous initiatives. And we are extremely inclusive about the number of partners we have. I like the point about third sector and not-for-profit providers. One of the things that I think is interesting is how kind of nimble that not-for-profit providers are. We've got a number of them, the hospices and 2 large community providers, and they're really good at doing things quickly and making changes. One of the things that I think the challenge is for the network working with them is how you scale that up. Eventually, once you reach a certain scale, a small team of people with a relatively high level of control can't do everything. So it's how we, and I sometimes use the kind of the language of terrorism. So sometimes you want terrorist cells of that kind of innovative thrust that the not-for-profit sector has, and how we bring some of that into the NHS. And one of the ways of harnessing that within the NHS is to use the loyalty that people sometimes have to their clinical specialty, not to their institution, and giving them a bit of freedom, giving some earned autonomy to small groupings of clinicians. One of the things we'll do in South London, and this comes out of a positive experience we've had in London changing stroke and trauma care, is to have strong involvement of patients and advocacy groups right at the beginning. When we changed stroke care in London, in the board that decided what we did, we had patients and stroke association representatives at that level. So instead of developing plans and then going asking a bunch of patients if they're all right afterwards, we had them in the room defining our plans. It was useful at that level. The other use of it was often clinicians have a habit of batting for their institution and their profession before they bat for the patients. So when we're trying to change stroke care across London, you'd have people trying to preserve the integrity of their local stroke unit, but forgetting the fact that the mortality in their stroke unit was 25% higher than one 7 or 8 miles away. And it was actually very useful having the Stroke Association at the table who said, actually, that 25% mortality difference is completely unacceptable, let's sort this out. And so getting people right in at the beginning is really important. I'll move on to the next slide, which is to talk about our values in South London. So we want to be innovative. We're going to evaluate everything we do, and I'll talk about that in a bit more detail. We do need to have a very close relationship with education. There's no point the healthcare professionals of the future being educated in the pathways of the past, and so we do need to work extremely closely with our local education and training board, which we're going to do, and we need to collaborate. We need to collaborate across the network, and we need to collaborate within and without the NHS. I think our strategic approach is reasonably clearly described by the name, by the Academic Health Science Network. So it's about health. So when we've chosen our priorities, which I'll move on to shortly, our priorities have come out of the Joint Strategic Needs Assessments, which are done borough by borough. And the moving of the brief for public health into the local authorities territory with the health and wellbeing boards, I think is a very welcome move, and is certainly a vehicle which stands a chance of bringing health and social care much closer together. The proof of the pudding will be in the eating, but it does stand a chance, and it's something I welcome. So we've chosen priorities that are of public health significance, and I make no apology for that. The academic bit is really important, and that's about evidence base and evaluation. But I think we've got to think about that in quite a sophisticated way. So when we're redesigning the pathways through which patients travel, we've got to look at what's the best evidence base for the best pathways, but we've also got to develop the best evidence base when it's not there, which is the bit about research participation. However, it doesn't just stop at that. The evaluative rigour, which the academic bit of a health science network brings, mustn't stop at the clinical science. It's got to look at the improvement science. It's got to look, what it is about what we did nationwide on MRSA that we got right and allowed us to reduce the rates of MRSA by 95%. So we've got to evaluate the improvement and the process as well as evaluate the clinical science. But then the third bit, because otherwise this all gets a bit utopian, is health economics. So every single pathway that we try and redesign will also put in a health economic analysis. If we don't do that, then commissioners won't buy it at the end of the day, and there's no point. So there's no point having as I say, a completely utopian idea about what's best. It's got to have a health economic element to it as well. And I'll try not to use the stroke example again, but if you look at the work that was done in stroke in London, there was a leap of faith at the beginning where the NHS London leadership said that we will invest in the first 72 hours of stroke care because it will come back to you in the end. There's a leap of faith. But at the end of the exercise, there's a health economic analysis, and that shows that the first month of care, which involves an investment in the first 72 hours, costs more money. The first 3 months of care across London saves £5.4 million a year, and that's real money because that's money that we've now measured. Over 10 years, it saves something like 20 million pounds recurrently. And the interesting thing about that is most of that long-term saving is in social care, not in health. And so in some ways that innovation has broken the mould of the health service holding on to its bit and not linking in with social care. And we've got to get out of that. And I hope the network and the partnership and the placing of public health within local government is a route through that. But we've got to make some of those leaps of faith. But I think we've got to support that by investing in health and economics at the beginning, quite sophisticated health economic evaluation to make sure it adds up. And then the final point about the network is obvious, really. So the things we're going to try and do as a partnership are areas where there is added value from the partners working together. So we're not just working together for the sake of it, we're working together where it works. And I think that comes out in the priorities we've chosen. So this is the way we've set about writing our bid. So in pink are the 4 of the 6 areas: research, education and training, service improvement and wealth creation, that were part of the key functions talked about in the central guidance. And research divided up into participation, which is good, and translation, which is rolling it out to populations. There's an important enabling bit about informatics. And the informatics, I think, has got a number of components. One is the very simple thing, but it's the simple thing that Connecting for Health hasn't succeeded in doing, which is allowing data to be shared across the partnership. And we're going to put a substantial investment in the first year in trying to enable sharing of data between partners. And it's this inability to share data between social care and health, between the statutory sector and the rest of the world, between the NHS and the private sector, but between primary care and secondary care, and between acute care and mental health, etc., etc. Patients fall into this gap, and in some ways we set these systems up to suit us and to suit institutions, not suit the patients we serve. There's also an important bit about information, about providing information so we can evaluate what we're doing. So everything we're doing, as I said in the last slide, we'll be evaluating. And then the third bit's the really simple bit, the bit about using data to drive up improvement. And I really, really do like the EQ stuff that KSS have been doing. And I've talked to some of the people in KSS about this, and I think we should do what I think someone was suggesting earlier, which is that we should steal stuff that's good. And it is important that the AHSNs work together. And actually I think that will work better again by kind of behaviour and culture than by setting up structures. I think the network of networks is important, but it's much more important that we talk to each other across networks. And there's quite a lot of that going on already. We talk a great deal to the other London networks, and we talk a great deal to KSS. And in fact, I'm going up to Nottingham in a couple of weeks' time to try and see what I can learn from their network. Okay, and then down to the bottom of the slide, which is our priorities. We've picked 4 priorities. And kind of back to my point at the beginning, which is that I think it's important that when we pick our priorities, they're aligned to public health need, and our 4 priorities of diabetes, dementia, the musculoskeletal pathway and alcohol are. But also, we've made an active choice to pick relatively specific things. The reason for that is I think we stand a chance by being relatively specific of doing something early on. And if we do something early on, then I think the membership will gain some confidence in what we're doing, and then we're more likely to do some of the more difficult stuff later. So we made a relatively active choice about that. We have, since our bid went in, we've developed 2 more themes. One of which is cross-network working, which is mainly going to be with London, but not exclusively, and we're going to focus on cancer and cardiovascular disease in that. And the second is a group which we haven't really got a name for it, but we're calling small themes, where there is stuff that's done really well in areas which are of slightly less great public health need, but where good stuff is done. And one, we don't want that good stuff not to thrive, but I think more importantly, there might be general learning from that. And I'll use an example. There's an existing clinical network for sickle cell disease, which covers South London and Kent, Surrey and Sussex. That has strong links with industry already, which is helpful, as we already have in dementia. Has strong links with industry already. Has very high levels of multidisciplinary involvement in the delivery of service, so psychologists, nurses, patient groups, and doctors working together. And I think quite interestingly, has very high levels of patient participation in clinical trials. And this is a group of patients who are young and black, and who traditionally have not been high participants in clinical trials. So something that this group of people have got really right, and they've developed quite strong protocols across all the providers in Kent, Surrey and Sussex and South London to deliver consistent high quality care across this disease. So there's a huge, and quite a lot of that is not specific to the disease. So there's a lot of important learning we can get from that, and that's the kind of area we might invest in our small themes. But the condition of that will be an evaluative rigour that means we can pick up the general lessons from that and apply it to other areas. Okay, I'm only going to go through this slide kind of very quickly, but this is the way we're going to approach service improvement. But really, I just need to go across the top really, which is I think we're not bad at looking at public health data and setting prioritisation. We're not bad at looking at the evidence base and developing a case for change, or even saying what best care would look like. What we're hopeless at doing is implementing new models of care. And that's the problem, I think, that the AHSN needs to solve. And I think we need to look much more carefully about the way other people do that, about the way industry does that, about the way the third sector does that. I was talking with the chair of St George's Medical School last week, and she used to work both for British Airways and Sainsbury's. And when she worked with both of those, she was involved in big kind of organisational development projects. And one of the things she said they did with Sainsbury's one of the features of Sainsbury's is she said there was a kind of culture of obedience within Sainsbury's. So when they decided they were going to do something, there was a lot of discussion and debate and you know, quite a lot of resistance when they were trying to do something new and different. But once they decided to do it, it kind of happened. And that's just kind of weird in the health service. In some ways, a board decision in an institution to do something is the start of a negotiation, not the end of a decision. And so there are an enormous number of cultural things as well as practical things that we can learn from without the NHS. And I was talking to her about how we might send some of our pairs of our managers and our clinical leaders out into that sort of environment to see that you can do it differently. If any volunteers for placements, then let me know. Okay, I've talked quite a lot, so I'm not going to talk. I'm not going to talk in detail about the musculoskeletal pathway, but I will just very briefly say we spend a lot of money on this. We have long waiting times, and actually we deliver slightly indifferent care. There's also an opportunity in this pathway with a kind of need to increase physical activity to increase the health of people. Knee pain and back pain cause an enormous amount of sickness, absence and absenteeism, and one of the things we might do with our work on staff and our kind of physiological measurements is try and get our staff healthier, and that might be something, it's a horrible word, we can productise and work in other areas. But I'll go through this because I've talked quite a lot already. Okay. So this is my last real slide. So I'm not going to talk about the governance, about the way we do it. We are just about to appoint a chair. We're going to appoint a chair whose whole career has been in industry. I think it's very tempting for NHS organisations to keep appointing non-execs and chairs who are like us, to appoint kind of public sector greybeards, and we won't do that. And I think it'll be very important that he holds me as the managing director to account to make sure we deliver on all that. We will have what I hope is quite a dynamic industry advisory board, which he will chair, not the executive. But actually, I think the interface between us and industry will not be up there in a very theoretical way. It's got to be down at the themes. And one of the nice things that's happened already is people are coming to our door and are beginning to see us as a kind of developing single portal of entry into the population. And I think working together, particularly with the AHSCs, who've got quite a good track record on this with life science, that we need to put our collaborations right down at the theme level, not up at an advisory level, advisory in the board. The final thing I'd kind of like to say here is next to our themes I've put fellows. So our evaluative rigour we're going to put in each theme by putting fellows in there. The fellows will do the bit about the clinical evidence base, the developing the clinical evidence base, the service improvement science bit, but also the health economic analysis. And those fellows we expect to be relatively young, bright people who come from all kinds of areas, and we want to be quite imaginative about who those people are. So we'll have some clinicians, but from multidisciplinary background. We'll have some bright young NHS managers, mostly people from the graduate training scheme, but also we're hoping to get some exchanges of people in and out of industry, and we'd hope to be able to be quite creative about sending people backwards and forwards to get some benefits. And I hope that will give us some of the cultural benefits as well as some of the practical benefits. Okay, and this is just the process. So like others, we've got our feedback session next week, and then we hope we'll have an interview and get our licence in April. But I'm kind of itching to get on with it and nervous that we'll become kind of monolithic before we do anything. And I think it's important we do something before we become monolithic. Thanks very much.
Thank you.